I'm the president of Sokol San Francisco. I'll be today's moderator. I want to thank you all very much for taking the time to be here tonight and for helping us welcome our very, very special guest, psychiatrist Dr. Jaroslava Salman. But because we're among friends tonight, we'll call her Yara. As Yana mentioned, tonight's presentation will be recorded, which means that if you are speaking and on camera, it means you're agreeing to being recorded. Of course, you can turn your cameras off if that makes you more comfortable. When you're not speaking, Yana also mentioned, please keep yourselves muted. And if you're experiencing any sort of audio or visual issues, let us know as they arise and we'll try to tackle those. Today's format's pretty straightforward. I'll be asking Yara to tell us a little bit about her background, what led her to medicine. Then we'll talk more about the substance of what she does and what led her to write her book. We'll have a dedicated Q&A at the very end of her talk. But if you have questions throughout, you can chat them, you can raise your hand physically or virtually, and we'll try to weave those in. We really want this to be an interactive sort of dialogue together. Okay, with that, Yara, it's a pleasure to introduce you. And do you want to share your screen at this point?
I can, yes, because the first couple of my slides actually um, include some information about my professional background. So,
I think it's always good to have our speakers talk us through their story, how it is that you got to where you are today, and especially sort of the real crux of what we'll be talking about, which is what led to your book, of course.
okay, you guys are seeing my screen?
Yes.
Yes, we
Yep.
are.
Okay. So actually, the title of this presentation is Hope Without Guarantee, which is a direct translation of the book that I co-wrote with my friend journalist. I'll tell you more about that as we go along. Um, so um, uh, my goal is actually to talk about um, the psychological impact of cancer on the person who has the cancer, but also on people around them. But at the same time, to make you aware, let you know that we did write a book. The book is currently in Slovak and it's available on Slovak and Czech market for people, for general public to really help educate and provide information about various topics that pertain to the psychological impact of cancer. So, as far as my professional background or my educational background, so I'm from Slovakia. I was born in a city called Košice, which is a second largest city in Slovakia. It's in eastern Slovakia, very close to the Hungarian border, where I actually went to University of PJ Shafarik. It's one of the three medical schools in a very small country. Um, and after I graduated from the medical school there, I worked, my first job was actually at a psychiatric hospital in a lovely, lovely, I think their history goes back to like medieval ages, town called Kremnica, as you can see in that colorful photo. It's a beautiful town nestled in this, surrounded by these beautiful, beautiful mountains in the middle of Slovakia. And it was an amazing experience to work in the psychiatric hospital that was very big and allowed me to learn a lot my first year at work and see all kinds of patients, but not really patients with cancer. So it was a fantastic first year experience for a fresh doctor. But then a year later I actually moved to Los Angeles to um, be with my, initially it started as a visit of a friend whom I've known for several years, and that friend eventually became my husband. So Los Angeles really has been my American home since 1999. We have not really lived anywhere else. um, and I came here without sort of the ability to start working as a physician, and I obviously had to go through all of the licensing exams and enter residency, which is a specialization training for every physician in the United States. And for psychiatry, it's 4 years. So after several years of living here, I was able to enter the residency program that was here in Los Angeles. I was very lucky. I consider myself extremely fortunate to be able to do that. And then that um, followed by a 1 year fellowship in what's called consultation liaison psychiatry, which is a subspecialty in psychiatry that um, m- deal means that my expertise is, taking care of patients who have some kind of medical illness, and it can be any kind of medical illness, but generally we practice in general hospital or in specialized clinics. And along the way, while I was in my fellowship, I actually had the fortune to work with a psychiatrist who was also specialized in palliative care. I had no idea that that's possible. And he was a physician at UCLA. So he was my teacher for a period of time. And that was the first time that I realized, wow, a psychiatrist can actually kind of work within the field of oncology and be helpful to those patients. So that experience sparked my interest in oncology. Um, and then after my fellowship, my first job was actually at University of Southern California, where I worked at the university hospital, and I started working some more with patients at their Norris Cancer Center. So I did a lot of sort of usual hospital psychiatry, and I worked with a lot of transplant patients. But this was kind of my first real opportunity as a already trained physician to start working with patients who have cancer and start building that interest. And it was at that point that I realized, you know what, I really would like to do this full time. How do I get a job like that? How can I work at an actual cancer center? So I literally cold called City of Hope, which, if you're not familiar with City of Hope, it's a wonderful hospital with amazing history in Duarte, California, which is kind of just outside of Los Angeles or next to Los Angeles. It all blends together, but it's a short drive from my home. And I called them and I said, "Hey, if you guys ever need a psychiatrist, I really would like to work there." And lo and behold, they were looking for somebody at that point. So I got very lucky, and I actually was able to start working at City of Hope. It was the very end of 2014, and it was an amazing experience for almost 9 years. After 9 years, full disclosure, last year I transitioned to another job. I now work at Kaiser as a transplant psychiatrist. So I switched from oncology to transplant patients. But it was the experience at City of Hope that really made me realize how crucial not only the psychological care, or I would say whole person care, um, means how important it is for patients who have cancer, who are going through cancer, but how important it is for people to actually be aware of that something like that is not only important, but it exists, and it's okay to ask for it, and it's actually now considered to be a standard of care to have access to that kind of support. And I'll just add to the picture that you're seeing on this slide that I think when people say Los Angeles, many people imagine jammed highways and I don't know, the skyscrapers downtown. But I live near these beautiful mountains that I can see every single day. This is a picture from one of my favorite places here, Descanso Gardens. So if you're ever visiting Los Angeles and you want to go, please let me know. I'll take you. I love taking my guests there. Okay, so let me say a little bit more about the City of Hope experience. One of the, um, I think one of the big reasons why I was so excited to start working there was that when I first came for an interview there and I met with the then medical director of the hospital, wonderful, wonderful Dr. Sandra Levine, um, she told me about the first director of this hospital, Mr. Samuel Golter, who was the first medical director in the 50s. And City of Hope started as a tuberculosis sanatorium back in 1913. Um, but it was Mr. Golter who said that there is no profit in curing the body if in the process we destroy the soul. These are profound words. And when I heard Dr. Levine say those words to me, I said to myself, wow, this place knows what I do. This place will appreciate what I do as a psychiatrist, what I want to do as a psychiatrist. I was sold in that moment. I was like, yes, this is where I want to work. And if you ever come to the campus, this gate is in one of the gardens that you can see there. Anyway, I had the fortune to be a member as a psychiatrist, to be a member of the Department of Supportive Care Medicine, which is really a unique department, unique in this country because it's incredibly multidisciplinary, meaning that it encompasses different disciplines, different expert specialists who are all there to take care of the patient, but not only the patient, but also their loved ones. So I'm not going to go through every specialty, but you can see that psychiatry is part of that, right? Then there are psychologists, there are child life services. So, for example, if a child has cancer, or if um, um, member of the family where there are small children have cancer, these are people, these are experts who can talk to these kids and help them through that experience, whether they themselves have the diagnosis or they're members of the family, because it has a significant impact on everybody in the family. Of course, spiritual care, volunteer services, and so forth. So it really was an incredible privilege for me to be part of this department, to be a member of this group of people that were incredibly compassionate and really there to deliver the best care possible, and really attentive to patients' emotional needs, psychological needs, and well-being, not just patients and their families. Um, so, before move on, I want to give you just a little bit of information on the history of psycho-oncology. If you've never heard that term, and I think for people who are outside of medicine, outside of sort of my field of work, they rarely hear the term psycho-oncology, and they're wondering, like, what does it mean? What is that psycho-oncology? Sometimes even physicians would say, like, why would a psychiatrist be needed in an oncology clinic? It didn't make sense to them. Um, so the cradle of this field of psycho-oncology, of the field of psycho-oncology, is really here in this country, in the United States. It was here where the interest and the idea that there needs to be an attention given to psychological needs of patients, to their well-being, was kind of sparked here among the psychiatrists. One of the well-known, unfortunately, she passed away in 2018, but one of the founders of this field was a psychiatrist herself, Dr. Jimmy Holland. And Dr. Jimmy Holland worked at Memorial Sloan Kettering Hospital in New York as a psychiatrist. And her husband was an oncologist. And she used to tell a story that they had sort of meetings with other oncologists in their home. They hosted um, meetings, parties, and then she would listen to her husband and his colleagues talk about patients. And it was during those times that it occurred to her that she was like, well, wait a minute, who's attending to these patients' sort of psychological health, how they're feeling, how they're doing? And those were sort of the seeds of the idea that there is more to taking care of a patient with cancer than just, quote unquote, just the diagnosis, the decision about the chemotherapy and surgery and radiation. There is so much that happens for that person and for those around them, that we need to pay attention to that. So, in the history, sort of the evolution of the field, we went from cancer being an incredible stigma and shame. And mind you, that's still the case in some cultures or individually for some patients. I'm not saying that cancer is no longer stigmatized or that some people don't feel ashamed to have it, but there was a lot of that, early on. And then obviously we didn't have the treatments that we did. until maybe early mid 20th century, when really surgery and then radiation therapy allowed some patients to actually have a cure, to survive cancer diagnosis. um, American Cancer Society was established in 1913, and it was one of those societies, one of those organizations that really helped to sort of take apart that stigma, take apart those barriers for patients who um, needed care, who needed support. um, then the combination of treatments and the research into treatments really evolved very quickly to the point that now we are in the era where cancer diagnoses that maybe a decade ago, 2 decades ago would be a death sentence, they're no longer a death sentence. People can survive, people can live for many years, even with metastatic disease. I mean, we've made leaps and leaps in terms of prevention, detection, and treatment of the disease. And thankfully, uh, uh, along the way, there's also been a realization that we not only have to acknowledge that cancer itself has a psychological impact, that it's distressing to have cancer and to go through treatment, but that we meaning physicians, nurses, people who work with these patients, we want to be proactive in asking people how they're feeling, how distressed they are. And screening for distress and attending to it and treating it and helping patients has really evolved into being part of standard of care nowadays. So that's what nowadays, when the patient comes to cancer center, that's what they should be expecting as a standard of care. That somebody asks them how you're doing emotionally and helps them if they're distressed. I want to take you a little bit through sort of how I look as a psychiatrist when I think about patients, or when I've worked, or I still sometimes see patients with cancer in my current job, how I think about their experience and what they might be going through at these different stages of their experience with cancer, and what they may encounter. And as I speak, you may think, well, that's something to expected. That's of course that's what's happening. But I can tell you that in reality, patients often don't realize maybe that it's okay to have the emotions that they have. They're often afraid to talk about how they're feeling. Not afraid because they're scared that somebody will shame them, but rather they're not sure if it's okay to say it. They're not sure if it's okay to talk about these things with their oncologist, or even how to talk about these things with their loved ones sometimes. But these experiences are real, and just being able to share them and to be told it's okay to feel this way. This is, a lot of patients feel that way. That in of itself can be very um, helpful and even healing for some patients. So the time of the diagnosis of cancer is for many an unexpected event. I have met so many patients who would say it was a shock. It was something I did not expect. I had no idea. I was feeling fine. Or they'll say, I just had some mild symptoms and then I went to get checked and I'm told I have cancer. What? So it's often this kind of a bucket of icy water that's poured on somebody's head while the rug is being pulled from underneath them at the same time. It's a life shattering experience, family shattering experience when that happens. So for people to feel in shock, sometimes in denial for a while, angry, in disbelief, is very normal. That's a normal emotional reaction to have. And that can alternate with sadness, a lot of worry, a lot of anxiety. There is uncertainty. What does this mean? Okay, I got my diagnosis, but of course, people immediately go, what's my prognosis? And there is some period of time until they can find out what the prognosis is, right? So it can be a very, very tense period of time and difficult period of time. People often feel that they sort of lost control over their lives. And and I often tell patients that it's natural for us human beings to crave having control, and that we value that very much. And we manage to live in the illusion that we have control over our lives. And cancer diagnosis is that kind of a moment of crisis, of existential crisis, really, that kind of forces us to go full stop and pause and realize that, there is actually very little that we can truly control in our lives. And that feeling like I lost control is really just a realization that we don't have that much control over what happens to us in our lives. And illness, and even, you know, catastrophic illness, um, is not within our control necessarily. So patients get diagnosed. What happens is, after that initial shock, things settle down. Usually, for many patients, once they talk to their doctor and the doctor says, this is what you have, this is the stage, this is what we're going to do, these are, this is your prognosis, kind of thing. These, usually the information seems to be helpful for people. People usually want to have the information. The culture in the United States is such that physicians have an obligation to share that information, really, to the extent that the patient wants it, right? The patient can say, I don't want to know, or I want to know very little, and that's okay. But I think, and I'll make here and there a little bit of comparisons to how things, let's say, used to be in Slovakia or Czechoslovakia, former Czechoslovakia. But even when I was a medical student there, it was not really accepted. It was not really a common thing for physicians to disclose and provide all the information. And in fact, oftentimes families would not want the doctors to tell the patient what's going on. And their fear was often, or their argument often was, oh, we don't want them to lose hope. Because if they're told that, let's say, they have stage 4 disease, they're going to lose hope, and then it's over, right? Well, the research that has been done into, kind of looking into this particular question, do people really lose hope if they know the truth about their, or facts about their disease and the prognosis and so forth? And the research has shown that that's not the case. People do not become more hopeless. And in my experience, again, part of it could be sort of what patients are used to here in the United States. But in my experience, patients do want the information, and many of them find it comforting to know, because they know where they stand. And of course, it helps for them to hear that there are treatment options. And again, nowadays, there are many more treatment options than there used to be, even several years ago. So, depending on the type of cancer, because as you probably know, cancer is a one word that is very general, and there are many, many, many types of cancers, and each one has a different sort of um, um, perhaps requires different treatment, may have a different prognosis, different staging, and so forth. So there are lots of differences. Even within something like a breast cancer diagnosis, there are so many different types of breast cancers. If you put 10 women who all had breast cancer in the group, chances are that each one has somewhat of a different type of disease. So, depending on the type of cancer that one has, then the physician chooses, obviously, surgery, radiation, chemotherapy, and so forth. The reason why I say that, I know you know it, but the reason why I say it is because these treatments have an impact on the patient's physical functioning, on their experience, but also on how they do emotionally, how they cope with everything, because these treatments tend to have side effects. Fatigue is one of the most common side effects that people experience, whether it's due to radiation or due to chemotherapy or the more modern treatments of immunotherapy. And some patients struggle with fatigue for a long time. And it's one of those things that is not visible, right? So if somebody loses their hair and they don't put on a wig or a scarf, then it's obvious to everybody they don't have their hair. But if somebody's feeling very fatigued, um, it doesn't necessarily show, right? And so they're trying to function, they're trying to do things. Oftentimes, when the treatment's over, the family wants the patient to kind of get back on track, and and do things as before, but that person is feeling tired a lot, and they can feel tired for a long time, sometimes even a year or even longer. And of course, I have had patients who had chronic type of cancer, and they would be constantly fatigued. And it's hard for patients to explain that to others. So there are things that are there are sort of sequelae or consequences to the disease itself and the treatment that can sometimes leave a patient feeling a little bit like maybe not an outsider but misunderstood or not understood by others, because they feel that it's one hard to explain, or that others don't believe them, um, or they want them to get better but they're not getting better. They're frustrated with themselves that they're not getting better. Thankfully, many patients do get better and do feel better. So it's not like that's how it always looks, but I'm just pointing it out as something that patients can struggle for a long time. During the actual treatment, they can have a lot of, physical side effects that are difficult to deal with. For example, poor appetite, not wanting to eat. It was so common for me to see, a patient in the hospital and the family's there, and the patient has no appetite, or they have mouth sores and it's hurts to eat, but the family's anxious for them to eat, and they're pushing them to, you have to eat, because obviously we feel like we need to get the nutrition right. How are you going to fight the disease if you're not eating well? And that can become a source of struggle for the patient and for the family, sometimes hard to understand. The body changes can often be inevitable. Loss of hair, usually that's temporary, and the hair grows back. It depends on the person, and how important their hair is to them. I've had patients for whom it was not a big deal. I have patients for whom it was a really big deal. And we can't, judge that, oh, it's just hair. If that is something that's important to that person's identity, I understand. It's very individual. Unfortunately, sometimes the loss of a body part, it's coming to terms with losing one's breast or both breasts or a limb. For some people, having colostomy for a long period of time. So even if we are much more successful in treating cancer nowadays, and it has people live longer and can survive, many more people can survive. So that's a wonderful, great news. But I think we still need to be sort of aware that the impact that the treatment and the disease can have on a person does not go away immediately or when the treatment is over. And that um, impact is not just physical, but also emotional. We hope for everybody to get into the point of cure, meaning that there are no traces of cancer and that person is clear for the rest of their life, and the cancer doesn't come back. That's a hope and goal for everybody. But sometimes that's not possible. And what's possible for some patients is to get into remission, meaning that the disease is suppressed enough that it's sort of kept at bay, and that person is doing well. They can get back to their school or work and their usual life. They're monitored. They may have to be on some long-term treatment to keep the cancer at bay. They may have some side effects, maybe not too many, but it's possible. It's possible to have cancer in a long-term remission. And I'm talking about, for some patients, decades, depending on the diagnosis. Now, what usually happens after the initial treatment, the active treatment is over. So meaning let's say the surgery, radiation, chemotherapy, right? The oncologist will say, okay, we're done with the treatment. It's the cancer's gone. Wonderful, congratulations, we're all happy. Now we'll see you in 6 months. That in and of itself can be very anxiety provoking for patients. What, 6 months? I've been coming here every week. Now you just want to see me in 6 months. What if it comes back in the meantime? So there is anxiety about that. But at the same time, of course, there is a relief, and a relief particularly for family members. So if you have somebody, let's say, who's let's just say young mother, has breast cancer, she has to go through treatment, she's tired, she has to um, uh, sort of step away from some of her usual roles in the family or at work. So others have to step in, right? It's usually the partner who has to step in and help and so forth. So now that the treatment is over, everybody's sort of waiting for that person, the patient, to come back and things to return to quote unquote normal. And um, oftentimes people don't realize that the return to previous normal is actually not possible. And it's not possible because this is such a profound experience, changing everybody, whether they admit to it or not, whether they realize it or not, that things will never, ever go exactly to how they were before. And in fact, what's going to happen now is it's going to be kind of a quote unquote cliche new normal. Things are going to be different somewhat. Um, and even the patient changes. Even the patient feels like what they experienced made them a different person. Not that they're entirely a different person, but it impacted them profoundly. And they want and need the time to process that. But when there is a lot of pressure to come back to what it was before, come back and do this, be the same person you were before, sometimes they can feel conflicted about that, and again misunderstood, right? And as they're white knuckled their way through the treatment, because that's sort of what you need to do, right, to brace yourself to handle the recovery from surgery, to get through the radiation, there, during that time there isn't that much space to think about what's going on, to think about the emotional impact. And so as a psychiatrist working at the cancer center, what would happen, what I would see, is people would come to me, to my office, let's say a few times after the cancer. Not all of them, but some of them would come a few times after the cancer, and that was the time when it suddenly dawned on them, and they realized, what the heck did I just get through? How did I get through this? What do I do with all of this? What was important then is not important anymore. It's kind of like this awakening almost, or rearrangement of one's experience and view, and they need time for that. So just like people need to rehabilitate physically for something like that, they also need psychological or spiritual, emotional rehabilitation to recover, process what they experienced, if they can talk about what they experienced, and then recalibrate, come to terms with the experience. And for many, it is an experience that allows them to grow as a person. I can't tell you how many times I've heard patients say, I just changed my priorities. This really changed my priorities. The things that mattered before, they're not that important anymore. Something else is important now to me. So it's, for many, it can be an opportunity to reevaluate one's life and what's purposeful in life. And you could say, well, okay, you probably see the iceberg tip of all the patients that go through this. What about the others who never make it to your office? That's true. I mean, some of them maybe would have benefited from coming to my office. Some of them are the kind of personalities that maybe never really need to see somebody like me or a psychologist. They sort of shake it off and move on and keep going, or not. I don't know. It is very, very common for people to experience what's called a fear of recurrence. And I would say that it's not a diagnosis in and of itself, but it is a type of anxiety. It's a type of worry that is sort of unique to cancer diagnosis, because cancer is unique in a sense that it's the kind of disease that you can cure it, but it can come back, or some other cancer can pop up. And people know that, right? Patients know that. So they know that even if they got the fantastic news of being cured, in the back of their mind, they will never stop thinking, not constantly, again, it's individual, but it sometimes pops out, that thought, okay, what if it comes back? What if I get sick again? Right? And for some patients, it can be really, really intense. It can be really consuming, particularly the first maybe couple of years after the cancer diagnosis, to the point that they need help, whether it's, talking to a therapist or maybe even some medications to help them with this anxiety that can really take over their lives and make it difficult for them to function. I've had patients like that. The good news is that there are ways to help that. But I think as far as the fear, the type of fear that they experience, that is definitely unique to these patients. And then, dealing with the impact of treatment, I touched on that, sort of things that will not go away, things that sort of will become chronic, will become long term. How does one come to terms with that? How does one come to terms with the fact that they can no longer do certain things that were really important to them, whether it's physical sports or uh, some to some degree even work, that they have to scale back, that they cannot do the things that they were able to do. So that can be really, really hard for people to come to terms with. For many of our patients, for many people who get a cancer diagnosis today or who got it recently, it can become a chronic illness. Hopefully, a lot of patients will still get completely cured. But for those who don't, where the cancer is just suppressed, even some types of the metastatic disease, patients can live for a long, long time. But that also means that they probably live with some other chronic ongoing symptoms, including fatigue, sometimes pain, physical changes. Oh, and that one is very common for patients known as chemo brain, which is really kind of a type of cognitive difficulty. Usually it's a problem, a mild problems with memory or focus for patients. Those are very, very common issues for patients after, particularly after chemotherapy, that can also last for a long time. So, these are some of the symptoms that patients experience. Again, sometimes it's hard for them to explain to others that that's what they're experiencing. They can be frustrated by experiencing them, but nevertheless, they will have to come to terms with them and live with them unless they get better. And if somebody has not been cured and has a disease that's actually just suppressed, not completely eliminated, of course, there is kind of an ongoing in the background chronic of progression of the disease. And that brings me to the book that I wanted to talk to you about, but we could. Do you want me, Linda or Yana, pause here if there are any questions, or do you want me to continue? I'm happy to continue.
You're perfect. Yeah, absolutely, Otto. You're such a powerful speaker, and I think it was important for you to convey the message in its entirety. So I think that what you just shared with us was wonderful. You know, one of our participants, as I expected, I'm here sort of for personal reasons too, having had a mother who happened to have gone through cancer, specifically transplant related, and so much of what you're saying is hitting close to home, as I imagine for some of our participants would be too, either for them personally or for a family member. And Petra, would you mind sharing with us what you wrote and your thoughts and reactions to what you just heard? And Yara has not seen the chat, so um, go ahead.
Hi, Yara. And first of all, I think you are doing an amazing job in, supporting the cancer patients or their caregivers. Um, I have been in or am in a situation where I know it firsthand. My daughter was diagnosed with ovarian cancer 1.5 years ago,
Mm.
and the life is never the same ever, and it never will, and I don't think it ever will go back. And it's not necessarily a bad thing. What I wrote in the chat is that the mental resilience of the daughter, mine, and the whole family was the key to get us through. We didn't seek the help of the specialists like you. At that time, it was such a turmoil that didn't even come to my mind. But we did seek like groups, the support system, where I could freely talk about it. And through that, I became a very active advocate for the cancer patients and the caregivers. So I'm currently leading the cancer support group in Amazon, where I work, with unfortunately very growing, um, memberships. We have about 12,000 people in Amazon that we believe are impacted by a cancer. So it's not a small number. The numbers are growing. And there is a huge need for empathy. There is a huge need for knowing you are not alone. There is a huge need for, sharing the tribal knowledge, whether it is, positive, negative, and everything in between. So I just wanted to really say how important the work you do or you did before you moved to the transplant field is important, and that the support, the mental game and the mindset is what really got us through. I have to say my daughter is now in remission, so we got through that. It was not only because we got it early, but because we just really normalize it. So that was our coping mechanism. We had to. There was no any other way. And a word that I was afraid to say out loud, because it was my biggest fear, was cancer always. And all of a sudden, it's part of my life every single day. We normalize it. We normalize it, and we try to live our life with cancer, and that's what we do in the different ways. It is not paralyzing us. It's just part of our life as anything else, like our sports or the kids' sports. And that part, that normalization, I think it helped my daughter to really power through, to really think forward and thinking, okay, it's not consuming me. It's just part of my life right now, but it's not the sole center of everything. So I am going to do things that I want to do within the capacity and boundaries that or constraints that I have. And now she's back competing. She's a volleyball. She's an athlete, and she plays volleyball. So she's back competing. She's now in her junior year, and I can only, I could only smile when we were talking about the brain fog, getting a person in the high school, which is really tough, that has a brain fog and it's not recognized by the teachers. I can tell you it's not really fun.
Mm.
So we went through all of that. So I recognize every single thing you said. And I also will tell you one thing. It's when I'm talking to my support group or cancer support group, the members, they say, I struggle with my cancer diagnosis 2 years later. It's harder for me to accept
Mm.
it, or I have a harder issues with that than in the moment I was diagnosed. Because at that moment, you're just like you're on a train, right? You do what you have to do. And then all of a sudden, once you get and everything kind of settles, you start to really be having a thoughts, and having regret, not maybe regrets, missing your life. So really how you shift from feeling sorry and feeling, desperate or in despair, and think about it in, this is what it is, and what am I going to do with that? How am I going to turn it in something that is positive, I can build on, and I learn from?
Beautifully said. Thank you, Petra, for sharing. And I'm sorry that you and your family have to go through this, but at the same time, and especially for a mom, oh my goodness, my heart goes out to you. But the way that you described how you approached it as a family, you're absolutely right. It is very, very, it makes a huge difference in how the family kind of pulls together. And, you're talking about normalizing. I'm thinking acceptance, really
Yes.
healthy acceptance of the situation, the reality of one's life, right? And how do we approach it the best we can with the best resources that we have, and not let this crumble us. That takes a lot of strength. So, yeah, thank you. And thank you for taking on kind of supporting others and creating a support group. You're right. It's so, so important. And sometimes that's what, a family member or a patient needs. That sometimes that's all they need is to really have a space and time to feel like I'm not alone. There are others and it's possible to get through this. So, and it's interesting.
I will say one more thing because you said something very interesting, and I think that Simona is there, or Simeda wants to share her story as well. So you said it's acceptance, maybe more than normalization. It's both. And I realized that very early
Mm-hmm.
on. So acceptance brought me a clarity. If I couldn't accept it, I was always thinking like, what if? Why me? Why us? Accepting me brought me a clarity. I said like, this is what it is. What am I going to do? And then normalizing the situation came afterward. But the acceptance had to start first. And that's what I say, with acceptance comes the clarity. It gave me clarity what
Mm-hmm.
I needed to do. I decluttered my mind from all of those sorrows and all of the other thing, and focus on what was ahead of me, what I needed to do. And that clarity I needed at that moment, and I couldn't do it without the acceptance.
Mm-hmm. Absolutely.
I thank you too, Petra, for sharing the story. I thank you, I'm thinking about you and your daughter. Yara, I think Simona wanted to share her cancer story as well, but let's let you get through this next slide. Just as a time check, it's 7:53.
Sure, let's go to this next.
Really? Oh my goodness. I'm sorry. I took a long time. So, okay. Um, so the next slide, actually, you see in the picture myself, and on my I guess in the picture to my right, the lady with the flower jacket is my co-writer and my friend Vera, whom I actually known from since my childhood. Essentially, she was from the village where my father was from as well, where I spent some, childhood weekends and summer vacations. And so we've known each other for a long time. But it wasn't until a few years ago, I think it was 2018, when I went to visit my family in Slovakia, and I met with Vera for coffee. And she's a journalist by profession, by education and profession. And she's also a cancer survivor. And her mom was actually, at the time when we met, diagnosed with cancer. Vera's very familiar with that experience. And I've already been carrying this idea in my head about creating a book that would be for patients and families. It would not be a textbook. It would not be for physicians or nurses, although they can read it. But I wanted to create a book that would be a source of information for patients primarily, to really help them to know, and, as Petra said, normalize their experience, right? That you can experience all of this, and that's part of it, and this is how you can deal with it. So I carried this idea in my head, and when I met with Vera, I said, Vera, I have this idea, but I think it would be more powerful if the book also contains stories from patients. I don't want to be just talking at people. I want patients and families to be able to read somebody else's story. And so here is the book. Several years later, Vera did interviews with 13 people. Some of them are kind of celebrities in Slovakia. They're well known personalities. Some of them are just, anonymous people, or people who are not known generally, but they're all cancer survivors. And they all allowed Vera to interview them, and they all shared very, very openly, honestly, movingly, beautifully their experience with cancer. And then my chapters touch on sort of sadness, worries, sleep, relationship, how to talk to the people around you, and so forth, more from a psychiatrist standpoint, but spoken in a very lay language so that anybody can read it. The book got published in Slovakia in spring of last year, and we had this wonderful event at one of the bookstores in Bratislava, where we had a book launch. And it's been, as far as I know, from the people who have given us feedback, it's been very well received. And my dream is to actually do something similar in English, not with the same patients, but obviously with with new patients who would also provide interviews. And um, so I told Linda and Yana that I'm hoping that maybe some of you here who are hearing this, maybe you know of somebody who might be willing to be interviewed for a future book like that and provide their story, because I think there is value in sort of having a book like that also in English, and having it for a broader audience. And I know that we're getting short of time, but I will close with a quote from one of my most favorite people that I idolize, of course, Václav Havel, who said, um, "Hope is not the same as optimism. It is not the conviction that something will turn out well, but the certainty that something makes sense, regardless of how it turns out." And it was actually this quote, I just get chills when I hear these words. It was this quote that inspired the title of the book, Hope Without Guarantee, that we don't have a guarantee that things will turn out the way we want them to turn out, but we still can have hope that what we do and how we do it is meaningful. It makes sense to do it the way we're doing it. And I'll end there. Thank you. And here are some more resources for you, actually, for if you want more information. And then the two bottom ones, if you have families or friends in Czech Republic or Slovakia and they would like to purchase the book, you can let them know it's available. And I have a few copies with me here in Los Angeles. So if you want a copy, just email me and I can get you a copy.
And we can certainly provide, I know that it was on the first slide, we can provide your email address after the fact. What, we can follow up with all of our viewers. It's funny when you ever want to make sense of something, there is surely a Havel quote out there
Yeah.
to help you make sense of it. Is that right? There was a question that did come up in a private chat. The book is only features survivors. Is that correct?
Yes. As far as I know, yes, all of the people who are in the book are still alive.
Thank you for that. Simona, if you would like to share your story, feel free.
Thank you, but I'll probably let you go because it's almost 8 o'clock and I will keep it for next time. Yeah, because you
Oh, I'm
really.
sorry. I'm sorry I
It's
spoke
no,
for
it's
so
fine.
long.
No, it's okay. It's fine.
Yeah, I had a question as I was listening to you talk. I was curious about the differences you've seen when somebody has had psychological, I'll call it intervention, either as they're diagnosed during their treatment versus somebody who hasn't. How does that sort of, I guess the symptoms may be exacerbated. Is that right? Are there sort of, have you seen somebody who's received the intervention where you say to yourself, clearly, this is a necessary part of this because if we don't do this, X happens? That makes sense.
Well, I mean, yes, in my experience, but also there's been a lot of research already into this area. So we know that people who struggle with, and I'll say sort of significant symptoms, let's say of depression or anxiety, right, which are very common, that it can impact how they experience the illness, but also how they participate in treatment, right? So they fare worse if it's ignored, if it's not addressed. But again, I'm talking about something that's significant. I'm not talking about occasional sadness or, occasional anxiety. All of those emotions are normal. But part of the role of a psychiatrist or psychologist is actually to discern, is this still within something to be expected? And what are the ways we can support you to be better, to feel supported? Or is this at the level where you maybe need more treatment, more help?
And what role do drugs play in that? So I remember with my mother specifically, there was some concern about suppressing, for example, emotions that the doctors felt were healthy for her to have to go through, as uncomfortable as they were. And those included anxiety, depression. They didn't want her to be disassociated from the reality of the disease and its possible outcome. So at what is there such a thing as too much psychological intervention that would do more harm, I suppose.
Well, I mean, when it comes to medications, I think yes, they do need to be used judiciously, just like every medication. And again, this is where a psychiatrist can be very helpful to one, determine is the medication indicated, what kind of medication, and could it be helpful? I have not really, as far as like, let's say, antidepressant medications, I've never encountered that to be a barrier for somebody to really truly understand what's going on and be able to cope. It's kind of the opposite. I found them very helpful for people who needed them.
Petra has shared, she's asking where they might be able to buy the book. Petra, did that question get answered? As Yara was saying, she's got a
Yeah.
few copies. Okay,
Yeah,
good.
so yeah, it did. So I was a little ahead. Thank you.
Sure, sure. And Petra is also sharing a book that she is collaborating with Soul
I'm
Connect.
Yeah, I'm
Wonderful.
collaborating with the lady with that wrote that book. And there are really, although it's very focused on the breast cancer, there are really some good tips on how to deal with that, with the diagnosis, who to say, what to not do, what to not say, or what you don't have to say. And actually, we just had her, I just hosted a panel series where I have 5 panelists sharing like kind of tips and strategies for what to do when they have to work through the treatments. A lot of people just don't have a luxury to take time off. Also, that's not also necessary. So what are the benefits or still working and going through the treatments? What are the downsides and how you prepare for it? So she was one of my panelists last week. Amazingly,
Wonderful.
very much. She made it her mission and she built her company on that.
Petra, I'm curious, when your daughter was diagnosed and as she was beginning treatment, were you offered psychiatric care if your daughter or you, or your family members wanted it? Is this part of sort of a normal part of the, experience now in oncology?
No, it's not. It's not. And it's very disjointed, right? So you can ask your oncologist or you can ask your physicians, but I have to, agree with what Yara was saying is that's really it's very, the physicians and oncologists are really focusing on their field. And if you ask them, they probably will share with you if you want some your help. But when you are in the middle all of that, especially at the very beginning, it's such an over paralyzing, you know, uh, uh, you don't think straight, right? So you don't think of everything that you should be doing. So it didn't even cross my mind. I was like, my first moment was like when we heard that she has a tumor. It's like, I know it's bad. And my husband was like, no, it's not bad. It's just not going to be, dangerous or life-threatening. And all I was wanting to think, I was thinking about, I have to get educated. I have to understand the disease. I have to understand how I'm going to read the blood work. I need to know what treatments are there. I need to get so my whole time and my mind was occupied on really what do I need to do to really get her on some level of treatment so that we can feel like we are getting out of it. It's not getting worse. So mental health and helping it was just the last thing that I thought at that moment. It came later. It came later when I started, even for myself, right? And it's not only for the patient, it's for the caregivers as well. It's for the brothers and sisters, it's the family, it's impacted. So how do you really how, realizing and recognizing that it's just, and being tuned to it. That's where I had to do a lot of work on my mental mindset of giving myself a space that I'm not totally consumed of really how am I going to keep her alive, but how am I actually going to keep her alive and keep my sanity and sanity everybody around me.
Um, absolutely.
Yeah, Yarka, can I ask, did you find out that people who have a faith, who are religious, not some, zealots, but I think who have some faith in life, go through these ordeals in a more kind way?
It can definitely be protective. I think yes, I think a lot of people who have not, as you said, not necessarily have a religious beliefs, but they're spiritual. that they have some kind of spiritual um, um, interest, or that that's part of their lives, that can be definitely helpful as far as
That
coping.
having people praying for you or something like that, just the feeling of connection with people who are thinking about you.
I think that if it's something that's important to the patient, that they feel like that is important to them, certainly that can be helpful. But of course, I've met a lot of patients who, let's say, are not religious or don't even believe in God, and I wouldn't say they necessarily cope more poorly. They just cope differently rather than through, their faith. But faith can be very helpful, of course.
Because I have a friend whose daughter died when she was 30 years old, and she was struggling with cancer for 10 years. But they're a highly religious family, and it is very kind of admirable how they dealt with it and how she actually, of course, she is hurting till now. She died 20 years ago, but she really, I think it really helped her a lot, give her strength.
Yes, it can,
Yeah.
for sure.
I
If
want to give.
I'm
Yeah,
sorry, if
go
I
ahead,
can
go ahead.
add to it, through this, like where I went through the chemotherapy treatment, which was very aggressive, and I lost my hair, eyelashes, eyebrow, nails, and even technically, the doctor was very scared because I lost about 30 pounds in 1 week. And from the shadow, from our congregation where I singing, where I'm the member of the music ministry, so many ladies show up and tell me, Simona, I went through the same about 10 years ago, 20 years ago. Some of them show me, I lost my breast and, I'm a survivor and I have my birthday and I have nothing, only my like friends around, and we have a cake and we pray, and actually it's not about the cancer. The cancer is like, it binds the people together because they have something in common, certain form of suffering they went through. But I must say I am technically thankful for the suffering because I put it myself to this trouble. I went through the 13 IVF to have family, which was my one. And then, from that overstimulation of the estrogen, I got the cancer, aggressive breast cancer. And instead to have family right away, I was running behind the doctor and, I went right away for my biopsy. They, they confirmed that and they said it's very aggressive. I said right away in another 2 weeks, I have surgery. Another week, I start chemotherapy. Another 6 weeks later, I have radiation. And it was very fast. In the same time, my father passed from the cancer, and in the same time I was accepted on university and study psychology, which helped me. I had chemo break, and doctor sent letter, you cannot go to the school. I said, I will, because I'm happy that I'm go through it, because I have so many trauma on the past, and this gives me some kind of bridge to look on the life a little bit differently. And after I finished, I graduated with my degree in psychology, and I got continuous study, and I finished my MBA. And where I was sitting in a chemo chair, this actually I was thankful to the cancer, because I not want to disclose people that I have see something unusual, that I have letters from President Václav Havel and certain letters. I hiding there for a few decades. And when I was sitting around and and saw the lady and we talk around and have fun, and I saw some of them die, they don't make it. But I did. But I said, well, I cannot die because I have story to tell. And I became author, and I write my first book, Simeta, which is available. And I didn't want to write it. And on the back on the book, it's written, the story is supposed to be hidden and never release it after my death. But I think at this kind of point, the faith helped me to connect with other people who never ever tell me that they went through the cancer, even though I was trying to help them reach out and be with them, but also would help me to, writing down the story. And even though I promise Václav Havel, I will never tell that people. And if they are not ready for that, which will probably never happen, then after 2 decades, I write down the story, because when I was sitting in a chemo chair, I lost my hair, eyelashes, nail. My husband was next to me. He was very, very emotionally, but he was working. He was looking at me if I'm okay. And even though I was not well, and the nurses were wonderful, fantastic, I didn't mind that I'm losing my hair, that I lose my eyelashes, nail, and eyebrow, and things like that, because that was not important. For me, it was important to writing down my story. And after
I did that, I found my peace. And I'm not worried. I am what happens supposed to happen. If person of faith believe, anything is possible.
Thank you, Simona. Thank you. Yeah, I will let you sort of close it with any last thoughts, words.
Well, I just want to thank everybody for making time to be here this evening in the middle of the week. I really, really appreciate it. And and for those who shared, thank you so much. And thank you, Linda, for helping to make this happen, and Yana. And you have on the first slide, you have my email. So if any of you want to reach out to me, and um, feel free to do so.
Thank you. And a big thank you from me as well. Again, it's so nice to be able to connect with you all from various parts of the state. And I always have to make a plug for Sokol, otherwise I get in trouble from our marketing guru / tech guru, Yana. If you enjoyed, I don't know if enjoy is the right word. If you found tonight's talk informative, if you'd like to stay connected with us, please sign up for our newsletter. That is the best way to find out about events like this one and our other events, both online and in person. Thank you once again, Yaro. It was a heavy, heavy topic, and I feel like it's just the tip of the iceberg. And to Petra's point, sadly, we will probably all know somebody going through this. And the more resources we have, the more places to turn to, the more stories and things that can connect us and help us understand, the more we equipped I think we'll be to get through it.
I
Thank you
agree.
all very, very much.
Thank you.
Thank you.
Have a good night. Thank you.
Thank you.
Good night.
Good night, everyone.
Bye-bye.
Good night. Thank you.
It was so informative. Thank you so much. Thank you.